Most people think a stroke is something that just happens suddenly, a random event, no warning, no prevention. He was perfectly healthy, went to bed, and never woke up the same. For years, medicine told us the same thing, that strokes were largely unpredictable, that outside of blood pressure medication there wasn't much you could do. That belief is wrong. For millions of people, the very position they sleep in every single night is quietly and systematically raising their stroke risk. Not next decade, right now, tonight. My name is Dr. Xeno Phantom. I've been practicing medicine for over 15 years, with a deep focus on functional medicine, cardiovascular health, and the metabolic drivers of disease. What I'm sharing today is something I wish every patient had heard before they ever needed me. Let me tell you about Marcus. Marcus was 58, a high school football coach from Ohio. Not a smoker, not diabetic. Blood pressure at a manageable 138/86. His wife said he snored like a freight train. He'd laugh it off. One morning, Marcus woke up with his right arm completely numb and his speech slurred. His MRI showed an ischemic stroke, a blockage in a key cerebral artery. A full workup revealed severe obstructive sleep apnea with oxygen levels dropping to 74% during sleep. He'd been sleeping flat on his back for decades. After positional therapy and lifestyle changes, his apnea-hypopnea index dropped from 42 events per hour down to 9. He has not had another stroke in 3 years. Marcus's story is not unique. According to the CDC, more than 795,000 Americans have a stroke every single year, one every 40 seconds. Research increasingly shows that what happens during those 7 to 8 hours you spend lying in the dark, your position, your airway, your oxygen levels, your blood pressure fluctuations, is a major piece of that puzzle. Today, I'm going to show you exactly 6 science-backed ways your sleeping position is silently raising your stroke risk overnight, and give you a clear, practical protocol you can apply tonight. Point 1. The supine position. Why sleeping on your back is the highest risk default. This one surprises my patients the most. The position they've been told is neutral, the one they've slept in their whole lives. Many tell me they sleep on their back because they read it's good for the spine. They assume that if it's good for the back, it must be safe for the heart. Here's what's actually happening. When you sleep flat on your back, supine, gravity pulls your tongue, uvula, and soft palate directly backward. This narrows your airway. In anyone with even slight inflammation, excess neck fat, or relaxed throat muscles, normal during sleep, that narrowing can collapse the airway completely. When it collapses, your brain triggers a partial arousal. You don't wake up, but your nervous system fires a stress response. Cortisol surges, adrenaline spikes, blood pressure jumps, sometimes dramatically, in the middle of the night. These repeated blood pressure spikes strain the walls of your cerebral arteries. Over months and years, those arterial walls become inflamed, thickened, and more prone to forming clots. And clots block blood flow to the brain. Research across multiple polysomnography studies found that in some studies, over 63% of ischemic stroke patients spent nearly all of their sleep time in the supine position. The more severe the stroke, the more time spent on the back. That is not a coincidence. A study published in PLOS One and reviewed by the American Academy of Sleep Medicine found that obstructive sleep apnea, dramatically worsened by back sleeping, is associated with a 2-fold increased risk of ischemic stroke. That's 200% higher risk, a major, measurable, physiological threat. My recommendation: begin sleeping on your side tonight. Use a firm body pillow along your back to prevent rolling over. It takes 2 to 3 weeks to retrain a sleep position habit, but the effect on your airway is measurable within the first night. Point 2. The airway collapse crisis. Obstructive sleep apnea as a hidden stroke mechanism. Almost nobody talks about this the way it needs to be talked about. Most patients told they have sleep apnea here. It's not serious enough to treat yet. They assume it's a comfort issue, a snoring problem. Maybe it makes you tired. But stroke? That's a different category, they think. It isn't. Each time your airway collapses during sleep, breathing stops, sometimes for 10, 20, even 40 seconds. Your blood oxygen saturation falls. Your brain detects the deficit and fires an emergency signal. The sympathetic nervous system activates. Adrenaline floods your bloodstream. Blood pressure surges. In moderate to severe sleep apnea, this cycle repeats 15 to 80 times per hour, every hour, all night. Your cardiovascular system is hit with repeated stress responses, the equivalent of dozens of small emergencies, while you think you're resting. Each oxygen drop causes oxidative stress in your blood vessel walls. The endothelium, the inner lining of your arteries, becomes inflamed. Inflammatory markers like C-reactive protein rise. Your blood becomes more viscous and more prone to clotting. Your carotid arteries thicken and develop plaque. Every one of those mechanisms is a known precursor to ischemic stroke. A 2014 meta-analysis published in the journal Sleep found that people with obstructive sleep apnea had a twofold increase in stroke risk, a relative risk of 2.10. And according to sleep researchers, OSA occurs in as many as 70% of people who have already had a stroke, compared to roughly 30% of the general population, suggesting that in many cases, the apnea came first. My recommendation, if you snore regularly, wake up tired despite 8 hours of sleep, or have been told you stop breathing at night, get a sleep study. Many can now be done at home with a wrist device. Know your AHI score, your apnea-hypopnea index. Above 15 is moderate apnea. Above 30 is severe. Either number demands action. Awareness is not enough. Treatment is the point. Point 3. The oxygen crash. What happens to your brain? When oxygen drops overnight. This one concerns me most as a physician, because it happens silently, invisibly, and the damage accumulates long before any symptoms appear. I slept 8 hours, patients tell me. I didn't feel anything. That's the trap. We assume that if we don't wake up gasping, nothing harmful is happening. The brain is the most oxygen-hungry organ in the body. It's 2% of your body weight, but consumes 20% of your total oxygen supply. When blood oxygen saturation falls below 90%, which happens routinely in untreated moderate or severe sleep apnea, the brain enters hypoxic stress. Neurons fire abnormally. Mitochondria produce excessive free radicals. Blood vessel walls become inflamed. And cerebrovascular reactivity, the brain's ability to auto-regulate its own blood flow, becomes impaired. This means the brain loses its ability to compensate when a clot forms. The damage is worse. The stroke is more severe. There's also a hormonal cascade. Cortisol rises with oxygen drops. Elevated nighttime cortisol suppresses the immune system, raises insulin resistance, and promotes systemic inflammation, all of which accelerate atherosclerosis, the plaque buildup that drives ischemic stroke. Your body isn't in restoration mode during oxygen-deprived sleep. It's in survival mode, and survival mode, chronically activated, destroys the very systems it's trying to protect. A 2025 meta-analysis published in Geroscience, covering 43 cohort studies, found that short sleep of 5 to 6 hours was associated with a 29% higher risk of stroke incidence. The combination of sleep deprivation and poor oxygen quality compounds this risk dramatically. My recommendation: invest in a pulse oximeter. These small, inexpensive clip devices measure blood oxygen saturation in real time. Wear it for a night or two and review your minimum reading in the morning. A healthy overnight low should stay above 90%, ideally above 93%. If you're dropping into the 80s, that's a clinical signal that demands attention. Many smartwatches now include overnight SpO2 monitoring. Use it. Point 4. The nocturnal blood pressure surge. The spike. You never see, coming your doctor, measures your blood pressure in the morning, in the afternoon, but almost nobody measures what it does at 2 a.m. Most patients know that blood pressure is supposed to fall during sleep. A dip of 10 to 20%, what clinicians call the dipping pattern. They assume that once they fall asleep, blood pressure is no longer a concern. But in people with positional sleep apnea, especially those sleeping on their backs, each airway collapse triggers an adrenaline surge that spikes blood pressure mid-sleep. This is what researchers call non-dipping, or even reverse dipping, where blood pressure fails to fall during sleep, or actually rises above daytime levels. This means your cerebral arteries are under high mechanical stress during the very hours when your clotting system is most active. There's a well-established phenomenon. Early morning and late night hours see increased platelet aggregation. Blood becomes more prone to clotting. Combine elevated blood pressure with increased clotting tendency, and you have a physiological environment primed for stroke. This is precisely why strokes disproportionately occur during sleep and in the early morning hours. It is not random. It is biological. In patients with untreated obstructive sleep apnea, research shows they are 2.26 times more likely to develop hypertension, and their nocturnal blood pressure profile is consistently more dangerous than daytime readings suggest. Research presented at the European Society of Cardiology found that people with obstructive sleep apnea are 5 times more likely to develop atrial fibrillation, one of the most potent independent risk factors for cardioembolic stroke, responsible for 15 to 20% of all ischemic strokes. My recommendation: if you have known hypertension or sleep apnea, ask your doctor about ambulatory blood pressure monitoring, a device worn for 24 hours that captures readings throughout the night. This gives you the real picture. Also, avoid alcohol within 3 hours of sleep. Even 1 or 2 drinks dramatically increase airway collapse, spike nocturnal blood pressure, and suppress the restorative deep sleep stages that protect your brain. Point 5. The prone position trap. How stomach sleeping compresses. Critical neck vessels. Almost nobody talks about this one, and it deserves urgent attention, especially for younger adults. Most stomach sleepers have heard it's not ideal for the lower back, maybe for neck pain. But stroke? Not on their radar. Here's what's happening. When you sleep prone, on your stomach, with your head rotated to one side, which is anatomically unavoidable, you place sustained mechanical pressure on the vertebral arteries, the blood vessels running through your cervical spine that supply critical regions of the brain, including the brainstem and cerebellum. When the head is rotated for hours, these arteries can be compressed, kinked, or placed under chronic mechanical stress. In anyone with existing arterial plaque, arterial stiffness from insulin resistance, or any degree of cervical spine narrowing, this positional pressure can significantly reduce blood flow to the posterior brain. This can trigger posterior circulation TIAs, transient ischemic attacks, or mini strokes, that go unrecognized because their symptoms are subtle. Brief dizziness, fleeting visual changes, momentary loss of coordination. Most people attribute it to just waking up groggy. A rare but documented condition, Bowhunter's stroke, vertebrobasilar insufficiency triggered by head rotation, has been reported in prone sleepers. A 2024 case report documented a 25-year-old woman who suffered 3 recurrent cerebral infarctions, all in the posterior circulation, attributed to prone sleeping with her head rotated. Carotid Doppler ultrasound confirmed blood flow interruption in her vertebral artery due to positional compression. A January 2025 review in the Journal of the American College of Cardiology Advances specifically highlighted that sustained positional head rotation during prone sleep can chronically alter cerebrovascular perfusion in anatomically vulnerable individuals. My recommendation: transition to a side-lying position using a body pillow in front of you to replicate the comfort of prone sleeping while keeping your airway open and your neck neutral. Use a cervical pillow that keeps your head aligned with your spine. Neck alignment during sleep is not cosmetic, it is vascular. Point 6. The optimal sleep position protocol. What the evidence recommends and how to get there. This is the section to save, because this is where information becomes action. Almost every patient who learns their sleep position is a risk factor says, "I can't change how I sleep. I've slept this way for 40 years. I understand that. Sleep habits are deeply embodied. But here's what happens when you shift to lateral, side, sleeping. Almost immediately, the gravitational pull on your soft palate and tongue reverses. Your airway stays open with far less effort. Apnea events reduce significantly. Blood pressure dips properly during sleep as it should. Cortisol normalizes. Oxygen saturation stays consistently higher. Your brain gets 8 hours of properly oxygenated blood flow rather than 8 hours of intermittent hypoxic stress. The left lateral position is particularly beneficial. It improves glymphatic clearance, the lymphatic process that clears metabolic waste from the brain, which works most efficiently during lateral sleep. It supports heart function and dramatically reduces acid reflux overnight, which itself is associated with vascular inflammation. Right-side sleeping is also significantly better than supine. Research suggests it may reduce pressure on the heart and help maintain blood pressure stability, though left-side sleeping holds a slight edge in the metabolic literature. The practical protocol: 5 tools you can use tonight. 1. The pillow wall. Method: place a firm pillow or rolled blanket directly behind your back when you lie on your side. This passive barrier prevents unconscious rolling onto your back during deep sleep. 2. The tennis ball trick. Sew or safety pin a tennis ball to the back of your sleep shirt. The mild discomfort from rolling onto it trains your body to avoid the supine position. Clinical studies have validated this method as effective positional therapy for sleep apnea. 3. The cervical pillow. Use a pillow contoured for side sleeping, with higher loft to keep your neck aligned with your spine. This protects the vertebral arteries while maintaining comfort. 4. Elevate the head of your bed. Even a 15-degree incline, with bed risers or a wedge pillow, significantly reduces airway collapse, lowers the gravitational burden on the soft palate, and improves both oxygen saturation and acid reflux simultaneously. 5. Hydrate before bed. Correctly, dehydration thickens the blood and increases clot formation risk overnight. Drink 1 to 2 glasses of water, roughly 400 to 500 milliliters, in the hour before sleep. Avoid alcohol entirely within 3 hours of bed. It is a primary driver of airway muscle relaxation and apnea severity. A 2024 study in the Journal of Epidemiology and Community Health, involving over 72,000 adults followed for 8 years, found that irregular sleep patterns were associated with a 26% higher risk of heart attack, stroke, or cardiovascular death. Consistency matters. Position matters. Both together form a powerful protective protocol. My recommendation: commit to 30 days of intentional sleep position training. Use the pillow wall method. Track your position with a sleep tracker or position sensing app. Monitor your morning energy, mental clarity, and resting heart rate. The changes you feel within 2 to 3 weeks will be your strongest motivation to maintain the habit. Today, we covered 6 critical science-backed insights about sleeping position and stroke risk. Back sleeping collapses the airway and sets off a chain reaction of oxygen drops, cortisol surges, and blood pressure spikes that damage your cerebral arteries night after night. Sleep apnea doubles your stroke risk and goes undetected in tens of millions of people. Oxygen desaturation impairs your brain's ability to protect itself when a clot forms. Nocturnal blood pressure surges create the physiological conditions for stroke during sleep, and stomach sleeping, with its sustained head rotation, can compress the vertebral arteries that supply your brainstem. The solution: side sleeping, the pillow wall, cervical alignment, head elevation, proper nighttime hydration, and consistent sleep timing. The theme running through all of this is root cause thinking. Your sleeping position is not just a preference. It is a physiological input, one that affects your airway, oxygen levels, hormones, blood pressure, clotting system, and the structural health of your blood vessels. Every single night, for a third of your life. The body keeps score, and it responds, quickly, measurably, and often remarkably, to the right changes. So here is your challenge. Pick just one thing tonight. Set up the pillow wall, wear the pulse oximeter, sew the tennis ball into your pajama top. One change. Then track how your body responds over the next 2 weeks. Small changes, applied consistently, are how physiology shifts, how risk drops, how people like Marcus, who came into my office unable to explain why he nearly lost his life, go on to coach 3 more football seasons without another stroke event. You have more control over this than the medical system typically tells you. Use it. If this added value to your health, please like and subscribe. I post science-backed content like this every day. Take care of your brain. It's the only one you have. Good night.